Good morning, good afternoon, and good evening. It is a pleasure to have you all here today for our second spotlight session, in which current users of external irradiators showcase a recent work of theirs and share some insights around their methodology to benefit the wider community. I'm Zsófia Tallos, North American Sales Director at Extral, and we are joined today by Dr. Yanis Verginadis from the University of Pennsylvania, who will present his very exciting work on precise proton irradiation of the cardiac apex using the SARRP. Dr. Verginadis' laboratory studies a variety of topics in radiation, including but not limited to flash RT, radiation-induced heart disease, radiation-induced toxicity and inflammation, radiosensitization, and tumor microenvironment. Thank you, Yanis, for offering to present and sharing your time and knowledge. And with that said, over to you, Yanis.
So, hi everyone. First of all, thank you so much for the invitation. It was a pleasure for me to present here the extra webinar about the precise proton radiation of the cardiac apex using the SARRP. So today, actually, I will present a story how we use the SARRP and the unique imaging capabilities in order to develop a preclinical mouse model of radiation-induced cardiac toxicity. And then using this novel mouse model that we developed, we applied in a unique setup, in the proton room, the flash proton room that we have. And then I'll show you some very interesting data about the flash proton radiation and the flash pairing effects. So these are my disclosures. So we know that general radiation causes both acute and long-term toxicities. And here in a recent review that we had published like a couple of months ago, we summarized the most common both acute and long-term toxicities in different organs and different sites. For example, we have like brain toxicities, abdominal, lung, and heart. And for this project, we target and we focus on the heart toxicity, both acute and long-term, which involves some of the most common side effects are valvular disease, cardiomyopathy, coronary artery disease, and so on. So this is a very nice review from Bergom's group that illustrated all the heart regions associated with radiation-induced cardiovascular disease. And you see very nicely that there are many sites in the cardiac tissue that radiation can impact with different outcomes. And we know that cardiac tissue can be impacted from radiation therapy on these type of cancers. For example, like non-small cell lung cancer patients, esophageal cancer, breast, and so on. They get either direct radiation to the heart or incidental radiation to the heart. And we impact different sites and regions of the heart and with different outcomes. For example, if we focus on the apex of the heart, we have the ventricles, and you get mostly damage to the ventricles and also to the myocardium. We also get damage to the left ventricle, left atrium, and so on. So you see we have a very huge variability in terms of where the radiation hits and the damage that we cause post-radiation.
Sorry, Yanis.
So the same group, Bergen's group, they summarized again in
would you mind changing the display settings?
Illustration, the most common radiation-induced toxicity in mouse models. And we summarize here, for example, to have like pericarditis, conduction abnormalities. And again, we are very interested in the myocardial fibrosis for two reasons. One is because it's one of the most common sites, and then the second one is because we are interested a lot about the inflammation and the chronic inflammation which drives to fibrosis. So it's a very well-known site that can cause fibrosis as long-term toxicity post-radiation. In this review, actually, they summarized that most of the preclinical models that they studied the cardiac toxicity involve either the whole thorax radiation, which you understand that you also damage the lung and also the bones and all the surrounding normal tissues, sometimes even the liver and the stomach. Or they actually involve the whole heart radiation with big sizes of collimator, which actually again involves different organs at risk, for example, the lungs. And then the damage is not focused on the heart. So to overcome all these issues and focus on the myocardium, we started with the imaging capabilities of the SARRP. And what we did is that, first of all, we tried to avoid the lungs as much as we could and focus on the myocardium, the apex of the heart. So I'll show you some treatment plans that we developed at the very beginning to see how we target the heart if we damage the surrounding normal tissues of the lung, mostly the lung, and then how we ended up with this preclinical model that we developed. So here you see the different sides of the treatment plan, from axial, the very top, and then the left is the sagittal and the frontal views of the CT imaging from the SARRP. So in that panel, we use 60 gray using a 3x3 round collimator. The square collimator, and then we used conformal radiotherapy over a 75 degrees arc. So we actually tried that in order to minimize the damage to the lungs. And as you can see here with gamma H2 staining, which is a marker of DNA damage, you see that most of the damage happens on the apex and on the left ventricle of the heart without any damage to the lungs at all. So this actually is not actually true, because if you focus into the lungs, you'll see that there's a minimum damage because of the arc that we use. But then again, compared to the heart, the 60 gray is almost zero. So we also tried different models, including the lung, and I'll show you why we did that, because that's a more realistic setup, because we, in case of the breast or lung cancer, we're going to irradiate the lung as well. So in the second setup, we use 40 gray using two 20 gray, again, the 3x3 square collimator, vertical opposing beams. So one comes from the bottom and one from the top. And this is the treatment plan that we have for this setup. So in that case, you understand that we have a more clear damage to the lungs, to the left lung, the left lobe. And again, it's very clear where we target, mostly myocardium and the left ventricle in the heart. But now we have a very defined area on the lung. Actually, it's very nice because we have a very focal spot, 3x3 millimeter square damage to the lung. So I'm not going into details because everything is published. But what we end up doing is, in order to avoid the lung and just using only the cardiac, the myocardium toxicity and the focal radiation of the myocardium. So we actually use the setup. So we place the mouse on the platform, and then we actually rotated the gantry in order to have 15 degrees from the base of the platform. And in that setup, actually, we're able to avoid the lung toxicity, the lung radiation. And this is actually shown by the DVH histogram here, which actually shows the partial heart corresponds to the myocardium area, gets almost 100% of the dose if we consider the 40 gray as the final, as the goal, delivering the 40 gray. And then you see that the purple here represents the heart as overall, and this is actually expected because of the myocardium, the area. And you see that all the other parts, overall the lungs, the partial heart, the right lung, the skin, they get minimal dose of radiation. And this is actually confirmed by the gamma H2X, again, the same side that we radiate 3x3 millimeter collimator. So we characterized several, with several assays, both the acute and the long-term effects, but just give you the most common, actually the most important findings from the study is that we follow up the mice for long-term, 20 and 30 weeks post-radiation. And we found from the mycin trichrome staining, which stains the fibrotic tissue, if you see on the right, the quantification graph, we have a very nice dose dependent fibrosis development in the heart 24 weeks post-radiation. So something else that we did is we performed several assays, functional assays in the heart. This is radioactive absorption assay. So the less radioactivity the heart actually absorbs, it means that there's less function. And if you can see here with this bar, the black bar represents the 0 gray, which is the control, which is actually the maximum. And then with the 40 gray now, we see a reduction, a significant reduction in the uptake of this radioactivity, and then also drops even more the 60 gray. And surprisingly, this happened to both, excuse me, apex and the base. Just to remind you that we irradiate only the apex of the heart. but we also see the effect on the base of the heart. And this actually is something that the group of Carl Butterworth showed exactly the same, but they irradiated the base of the heart and they saw the same effects on the apex of the heart. So using this model, we're very interested also to see how using this model, if we can identify any biomarkers. And we have access to patients' plasma samples from different clinical studies, trials with both lung and breast cancer patients that have received radiation. And what we found is that this marker, which stands for placental growth factor, PLGF, it was significantly regulated post-radiation. And not only that, we found that the levels of the PLGF circulating marker was very significantly and positively correlated with the mean heart dose that these patients received. So, of course, we identified several other markers, and this is something that we are very interested in currently investigating. So, using this model now, and that because we have established and we have done several experiments with this model, so the question now is, if we use this model, what are the ability of flash PRT, proton radiotherapy, to ameliorate cardiac tissue toxicity? And for that, I will present that we have a very unique setup in our proton facility. So this is the research room, which is behind the whole. Actually, is the clinical rooms. And then if you see here where the arrow points, this is where the proton beam comes out of the wall. And very nicely, we have the SARRP, which is unshielded, and then it's on rails. So what we do is that if you look on the right side, we are able to align the SARRP because you see the lasers with the lasers aligned with the proton beam. So it's a very nice setup, a unique setup, and gives the ability to do radiation, actually image-guided radiation therapy. So if we go to the next, which is actually more zoomed in. So this is actually what we used in this setup to apply both flash and standard proton radiotherapy and see the effects on the myocardium. So the reason we have the platform upside down is because, first of all, the beam, the proton beam is fixed, so it comes only that way. It will not have the capabilities of the SARRP to deliver actually the X-rays with the gantry. So we had to come up with an idea. So we use these states in a vertical. So the mouse, if you see here, is in a vertical position, hung from the teeth, from the states. And the other reason actually we use this setup is because the mouse is stretched, and then we have a very an easier actually way to target the myocardium and avoiding any other organs, other risks on the surrounding area, for example, lungs and liver. So as you can see here, we designed the treatment plan. You see we can deliver the ISO center of the beam and the dose and the apex of the heart. And then we deliver the whole dose on the apex, avoiding any lung tissue. So on the right, we have again the gamma H2X to show that both the flash and the standard proton radiotherapy, they're able to deliver the dose to the myocardium, as you can see very clear here. So what we noticed that the flash caused a very significant decrease in the pro-inflammatory cytokines, for example, TNF-alpha, but most importantly, as I mentioned, that we're interested in the long-term toxicity and fibrosis, we stand also for TGF-beta, which is a very key factor that drives fibrosis. And as you can see here, in different time points, 2 and 3 weeks post-radiation, the standard caused a significant increase in the TGF-beta expression compared to the flash. And actually, this actually caused the activation of the smooth muscle actin, the activated fibroblasts, which actually drive the collagen deposition. And this is shown in the next figure here, that we have representative images from both trichrome staining and picrosirus red that stain the collagen deposition 30 weeks post-radiation. And these are the representative, actually the quantification graph showing that all the standard mice have significantly upregulated fibrosis in the apex compared to the flash. So we also performed echocardiography to evaluate the function of the heart. These are some parameters of the whole echocardiograph analysis. We have the left ventricular interval dimension diastole, ejection time, and relative wall thickness. And you see that in both cases, here the flash is preserved. Actually, the cardiac tissue that received the flash radiation is preserved. It's almost the same levels as DNR. Again, the last graph here, the relative wall thickness, confirms the fibrosis, because we have really huge relative wall thickness, significant upregulate in the standard. So after all this data, we decided to start a multi-institutional study, and we collab with Heidelberg and try to see if we were able to repeat the flash sparing effects in 2 different institutions. But now we switched a little bit, and then we, instead of using a single dose, we switched to a fractionation scheme, and we're able to deliver 3 times of 14.5 gray with 1 cm collimator. And the reason we use, just to clarify here, 1 cm collimator, which actually covers the whole heart, it was because the Heidelberg institution cannot go lower than 1 cm, which actually this is one of the limitations of our study, but we have to compare equal sides of the radiation and the damage. So that's the whole the design of the study. So we start with the gamma effects to be able to make sure that we deliver the dose. And 2 or 3 weeks post radiation, we analyze for RNA-seq, both the heart and also the bone marrow. We perform IF staining and cytokine analysis, and then at different time points, 8 and 30, 35 weeks, we performed 2D echocardiography and histological staining as the final outcome. So I'm going to share some slides. All of these are preliminary data and published data, and have very interesting findings. So one of the, just showing you like some representative data from the echocardiography. So we have significant change in the global radial strain. We also noticed that the endpoint, the 30 weeks post-radiation, we have a significant increase in the percentage of spleen weight over the body weight in the standard group compared to the flash, which means that these mice still maintain high inflammation in their body. And what we also noticed is that if you can see here in the skin, at the back of the skin where the dose happened, is that the flash mice have discolorized skin, where only the dose delivered like at the back of the heart, compared to the standard mice that you see that they have extensive inflammation and skin dermatitis, which means again that they're under probably like a high inflammatory phenotype. So we also performed some CBC analysis, blood count analysis at 2 and 3 weeks post-radiation. And again, all these are preliminary data because we haven't compiled all the data from the 2 institutions. This is just from us. Again, we have a significant increase in the red blood cells and hemoglobin in the standard compared to the flash, which also maintained at 3 weeks, although it's lost its significance, but we have the same trend 3 weeks post-radiation. So one of the most important actually questions we have is the flash sparing effect maintained actually between the young and the 8th mice. And what we did is that we used 48 to 50 work weeks of mice, again with the same settings of radiation. And what we saw is that we have a significant difference, actually not significant, close to significant difference between the flash and standard in terms of the survival benefit. Something else which is really important for us is that one of the SARRP mice, 8th mouse at the end of the actually 20 weeks post-radiation, they developed lymphoma. And we have some representative images from the liver, spleen, and thymus, and that was actually evaluated by a pathologist that this mouse developed lymphoma. So overall, I was able to show you that we established a clinical relevant mouse model of image-guided radiation-induced heart disease using the SARRP and the unique imaging capabilities. And then the flash proton radiotherapy was able to reduce both inflammation and also the cardiac fibrillous and fibrotic signals 30 weeks post-radiation. So we are currently evaluating the acute delayed toxicities, which is the multi-institutional study with the fractionation dose, and these are everything is ongoing and under investigation. What we noticed in the 8th mice that we still have preserved flash sparing effects with also a survival benefit, and this is something that we haven't noticed before, and it's really important. And then with the lymphoma development, we're thinking also that maybe this is of course under question. We haven't tried that in a tumor setup. If we are able to achieve reduction in the secondary malignancies using the flash radiation. So with that, I would like to thank everyone involved in the flash studies. There are many people, the funding, our collaborators, IB supporting the proton beam, and of course my people in the lab, collaborators and funding. And I will stop here and thank you so much for your attention. I'm happy to take any questions.
Thank you, Yanis. That was excellent. We already actually have a couple of questions that have come in during the talk, so we can start with those. And as for the audience, please feel free to type any additional questions you may have in the chat and we will get to them. So the first one is, would you envisage larger animal studies such as canines to advance this research? And could this be realistically applied to a clinical trial? And if so, how?
Yeah, that's a very good question. Yeah, we don't have any canine trial or like another species undergoing now. So of course we're thinking about that, and the ideal model will be the pigs because that's the ideal model for the cardiac toxicities. Unfortunately, we don't have anything now ongoing, but this one will be, if we translate that in the clinical setup. Of course, we have to perform some preclinical studies first, and this is what we propose to have orthotopic either lung or breast cancer tumors, and at the same time with this setup to irradiate the heart, and then see if the cardiac damage is exaggerated, like because of the irradiation of the tumor or not. So these are all under investigation, and if I think, if I just thinking like later on, if can be translated to the clinic, that will be applied to lung or breast cancer patients, especially the ones that they're based on the treatment plan that are going to get radiation to the heart. That's that's actually our goal. But we have to do some preclinical studies involving also tumor, because all these so far, all these mice are naive mice that don't have any tumor.
Thank you. Well, we look forward to seeing where this goes. And then the next question, we actually have two quite similar questions. One is, how did you integrate the SARRP image guidance into the proton beam? And the other question that's similar is, how do you ensure alignment between the CBCT and proton beam? Is there a validation step?
Yeah, all these are great questions. So the first question, actually, I'll go to the second part. So the alignment happened when we have the SARRP on rails. If you see on the previous image, and I can show you here. If you see here, these are the laser beams that they have. Actually, the red one comes from the SARRP, and the green one comes from the proton beam. Actually, from the proton research room, and we're able to align exactly the. Oh, sorry. Yeah. Okay, you can see now. So we're able to align the beams, the red and the green overlap. Every time that we do perform, actually, for the presentation mode. Okay, so every time that we do the radiation, anyway, so every time that we do the radiation, we always calculate there is a shift in the y-axis. So we calculate that on the treatment plan, on the murine plan before we deliver the dose. So we find the isocenter based on the SARRP, and then if there is a shift on the green over the red, we calculate that on the treatment plan. But the X and Z axis, everything is like overlapping 100%. So we don't have any issue. So this is the, as I showed you, the setup that we have here, that the SARRP is on rail and is exactly in front of the beam line. That's why we said that it's a unique setup. And we have, we perform the imaging capabilities, like the imaging here, and then we deliver the flash or the standard proton beam in front of the mouse. So this is why we call it image-guided radiation therapy, proton therapy.
Another one that follows up from this is, how precise is your targeting with this setup?
Yes, so For this one, we tried several setups, and again, I showed you the different treatment plans that we used before we established this model. And then for this one, we keep going with the same setup. So we actually tried so far two different setups. One is to rotate the states, the vertical states. So the beam, actually, this is where the paper was published. So the beam comes in against 15 degrees angle from the states. So we avoid any lung toxicity, any radiation to the lung. It's only focused on the myocardium. And this was actually shown from the gamma H2X. If you see here, the gamma H2X is focused on the myocardium and a little bit on the left ventricle. So it's very consistent. We have performed several gamma H2X staining, different time points, and different models and different days, and it's very consistent. The reason for the flash studies that we use this setup is, again, I mentioned that the proton beam is fixed, but again, because of the motion effect and the delivery of the flash dose like in a very fast manner, so we try to avoid all these things, and that's why we hang the mouse in a vertical position. So we stretch the heart, and then it's more feasible to deliver the radiation on the myocardium. So we are, I would say, 95% accurate that the even more like the dose goes to the myocardium only.
Thank you. Great talk. Did you see any toxicities during flash radiation therapy? I may be missed. What are the doses used?
So yes, that's a good question. So with this study, we used 40 gray single dose. That was the first study that we published. 40 gray single dose, both flash and standard. Yes, we did see toxicity because we see some acute toxicity, subregulation of TNF-alpha, TGF-beta, compared to the unirradiated, and some other cytokines. And then if you see at the very end some fibrotic data, although it's not significant increase compared to the NR, but still you have some toxicities. The significant differences between the standard and the flash, which the standard is always higher in terms of secretion of cytokines, pro-fibrotic signals, and fibrosis. That's the huge difference. But we do see some toxicity.
Thank you. And then the next one, the secondary disease observed in some of the animals. Do you see similar results in other proton studies that you have performed?
That's something that we noticed only in one mouse, and we understand that this is also a rare phenomenon that we know that in the clinic also the secondary malignancy is not something like very common. That's also why we're surprised that we got this mouse with lymphoma. There are specific genetic mice that we're planning to use that are prone to malignancies, and this is actually what we're planning to do. No, we haven't seen anything in the general, like the proton radiation setup that we have without the flash. This is the first time that we see development of malignancies. I don't know, it's possibly because we irradiated the large, like the whole heart. Just to remind you that in this study, we irradiated the whole heart, not the myocardium only. So that means that we also include part of the heart, sorry, of the lungs, and also of the thorax bones. So we're actually investigating now the bone marrow, and if we have changes in the bone marrow and some other markers from the CBC analysis, trying to evaluate why this mouse developed, or if it's something that we'll probably see in the future more and more. But in the flash, we haven't noticed any change.
Thank you. And I think because you mentioned the stage rotation, two similar questions popped up. One is, could you irradiate with multiple beams in a conformal manner? And the other one is asking if you could, in theory, perform arc-based studies.
All great questions. Yes, if you see here, when we actually developed the focal radiation model. This is just X-rays with the SARRP without proton beam. This is what we firstly used, the arc therapy with 75 degrees arc. And theoretically, yes, we would like to use that with both flash and standard. Although, you know, we face technical difficulties how we're going to deliver the arc over the flash if it's going to be continuous. That was easier setup because you deliver X-rays with the gantry rotating on the SARRP machine. Now we have a fixed beam, proton beam, so the stage has to rotate in order to mimic actually the arc therapy. But again, I cannot imagine that, you know, like the stage will rotate so fast in order to do the arc therapy with the whole dose of flash radiation. So it has to be, you know, 3 or 4 fractions. This is actually what we're currently investigating to do, like 3 or 4 fractions of flash, like in an arc manner. That's a great question. Yes, we're doing that.
Thank you. This one is an interesting one. When we are using the SARRP by itself, we often irradiate multiple animals with the same setup. Can you do that with the proton beam?
No, actually, we decided not to do it because then based on the depth, we have to calculate every time the different isotype. So again, just to remind that the proton beam is fixed, so we have to put every time like a single mouse on the stage, perform a CT scan, you know, put the isosender, deliver the dose, and then go back to the bunker to put the next mouse. So we cannot do multiple mice at the same time. Just like so far we have done like single mouse. We feel more confident, you know, that we deliver the dose exactly the spot that we would like and minimize any other toxicity. The other thing is that when you deliver the you know, the proton beam, if you have multiple mice, then you have the secondary energies that you know, they're scattered into the room, so you try to minimize that. So we chose to go by single mouse every time.
Thank you. And then unless anyone submits any more questions, then I have a nice one that could be the final question. Mm-hmm. What would you recommend to someone who is thinking about setting up a similar setup?
Sorry, repeat again.
What would you recommend to someone who is thinking about setting up a similar proton beam setup?
So first of all, again, we're very lucky that we have this unique setup to do image-guided radiation therapy. In the other case, if you don't have this option, then you have to make sure that you have the setup in front of the proton beam, and then you have to do multiple stainings with gamma H2X and evaluation that the beam hits exactly your target, which actually makes the things like more complicated, and they have to go like through multiple steps of evaluation. I think this unique setup we have, if you know, like other people can use the same setup, will be amazing. It's like an amazing tool, and they will make the life easier. So just because, you know, since you mentioned that, we have developed several other models that we work on that. We have developed image-guided radiation therapy on the pancreatic tumors, and also in the intestinal tissue that we are also doing several investigations with or without the flash. So using this unique capability. So I think that's something that people have to think about it and use the SARRP as image-guided radiation therapy for that setup.
Thank you so much. And given that we have run out of time, I think that concludes our second Spotlight Journal Club webinar. Thank you again, Yanis, for the fantastic presentation and for the responses, and to everyone on the call for joining us today. If anyone in the audience is interested in showcasing their work to the community, please feel free to get in touch with us. Also, please don't forget to follow us on social media and for all the recent updates and news. Goodbye now, and I hope you enjoy the rest of your days.
Thank you so much. Thank you, everyone.